Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues, we are having hepatitis B interactive workshops. That is the case-based discussions. Till now, we have studied 4 cases, acute hepatitis B. Then we discussed HBe antigen positive chronic hepatitis B. Then we discussed HBe antigen negative chronic hepatitis B. And last discussion was about hepatitis B related liver cirrhosis and liver transplant scenario. Today is another very important case history, that is the hepatitis B and pregnancy. We shall see that what should be the approach in a pregnant lady with hepatitis B. Should that lady be treated? Yes or no? If no, then why? And if yes, then when the treatment should be started? What treatment should be given to her? And for how long the treatment should be given? And what should be the aims and objectives of treating a pregnant lady with hepatitis B? So let's go to the case history. And as usual, I shall be discussing with you the scenario and then scenario-based questions, and I shall request you to note down your answer, and then we shall see what's the correct answer of that very question and why we say that this question answer is this and that specific. And in this way, we will learn how the clinical guidelines they can be translated into everyday clinical practice. So Bismillah ar-Rahman ar-Rahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. We are having the interactive workshops on the management of hepatitis B with the theme of translating guidelines into everyday clinical practice. And it's the 5th case history today. And this is the hepatitis B virus in pregnancy, how to manage such patients. So the case history is a 32 years old female presented to gastroenterology outdoor. She's 6 weeks pregnant with a positive HBs antigen on screening. She's asymptomatic, no symptoms at all. Her labs are hemoglobin 10 gram. This is the normal range. MCV 82 femoliter. Platelets 159,000. WBC 9,000. INR 1.02. The PT is 12 seconds. Albumin is 3.6 gram. Urea is 12 milligram. And creatinine is 0.9 milligram. So except this anemia, rest of the parameters, they are within normal range. Her bilirubin is 0.9 milligram, again normal. ALT 35, it's within normal range of the labs. AST is 29, again normal. Alkaline phosphatase 129. Anti-HCV non-reactive, anti-HIV non-reactive, HBe antigen positive, and her ultrasound is showing normal liver measuring 15 centimeter, no normal ecotexture, spleen is of 10 centimeter, portal vein diameter is 9 millimeter, and no ascites. This is the abdominal ultrasound. No comments on that, the pelvic. Hepatitis B virus DNA PCR was 120,000. So she has got mild anemia with E antigen positive and PCR of 120,000 international units with normal ALT and AST, and ultrasound also normal, normal liver. And this is the first time she has been found to be HBs antigen positive on antenatal screening. So the question to you is, what would be your next plan of action? What will you do next? Option A, no treatment required. Option B, you will calculate EPRI score and decide if she needs treatment. Number C, start intake aware. Number D, you will start TDF. And number E, you will start TAF. So basically one approach, the option is no treatment required. Second, you calculate the EPRI score because on ultrasound the liver is normal, but you will calculate the EPRI score, and if that is high, you will start treatment. C is she is pregnant lady, and you start treatment with entecavir, TDF, or TAF. So write down your option. Let's see what's the option. You calculate EPRI score and decide if she needs treatment. Because you cannot say no treatment required. She per herself may be a candidate for treatment. So that will be the option. And without realizing or finding out whether she needs treatment or not, if you start the patients or the antiviral drugs, this will not be a good option. Because why? We shall discuss this in the next slide. The EASL guidelines are: screening for HBs antigen in the first trimester of pregnancy is strongly recommended. In a woman of childbearing age without advanced fibrosis, like this, who plans a pregnancy in the near future, it may be prudent to delay therapy until the child is born. Pregnant women with chronic hepatitis B and advanced fibrosis or cirrhosis, therapy with TDF is recommended. So one scenario is that a patient was found, if the patient is found to be having HBs antigen positive on antenatal screening, and she was not known if she is positive, HBs positive or not before the pregnancy. So if there is no advanced fibrosis and the patient wants to plan a pregnancy, then the treatment can be delayed. But if the patient has got fibrosis, significant fibrosis or cirrhosis, then treatment should be started, and this treatment is with TDF, not TAF. Her EPRI score is 0.5. What would you do now? You calculated EPRI score and that is 0.5. So what would you do now? Option A, ask the patient to come back after delivering the child. She doesn't need treatment, and she should come after delivering the child, and then you will decide whether the patient needs treatment or not. Second option, put her on the treatment as her age is more than 30 years and she has got high viral load. This is the second option. Option C, ask her to repeat PCR after 1 month. Option D, ask her to revisit after 24 weeks of gestation with fresh PCR. And option E, ask her to revisit 1 week before delivery with fresh PCR. So these are the 5 options. One is you don't start treatment, ask the patient to come after delivering the child, and then you will think about the treatment. Second option is that you start the patient on treatment because she's 32 years old and her high viral load, it's more than 20,000, it's 1,20,000. C is that ask her to repeat PCR after 1 month, that is in the 4th month, or you ask her to revisit after 24 weeks of gestation. It means after at the end of the 2nd trimester, or you revisit 1 week before delivery with fresh PCR. Please note down your option. Let's see what is the correct option. This is ask her to revisit after 24 weeks of gestation with fresh PCR. Why? These are the hepatitis B treatment guidelines that screening for HBs antigen in the first trimester of pregnancy is strongly recommended. HBs antigen negative mother should be counseled for HBV vaccination. If the lady is HBs antigen negative, vaccinate her against hepatitis B. Family planning should always be discussed with women of childbearing age before initiating HBV therapy. The woman should be informed about the safety of the HBV drugs in case of pregnancy, that if she becomes pregnant, then there is safe therapy, no doubt. In a woman of childbearing age without advanced fibrosis, APRI less than 2, who plans a pregnancy in the near future, therapy can be delayed until the child is born. And pregnant women with chronic hepatitis B and advanced fibrosis or cirrhosis, that is APRI more than 2, therapy should be initiated. So, she visited at 24 weeks of gestation, and her investigations are hepatitis B DNA viral load 239,000, bilirubin is 0.8 milligram, ALT is 20, AST is 18, alkaline phosphatase is 210, and this is because of her being pregnant. INR is 1, creatinine is 0.7, and albumin is 3.6. So her viral load is increased. Initially, it was 1,20,000. Now this is 2,39,000. And rest of the parameters, they are normal except the alkaline phosphatase. And this is a bit high, the reason being the pregnancy, the placental origin. So questions come to you. What should be the next management step? Option A, no treatment required. Option B, start the patient on treatment. Option C, start treatment 4 weeks before the delivery. Option D, start treatment after delivery. And option E, start the patient on prophylaxis against vertical transmission. One is that you don't treat, she's pregnant lady, and her APRI score is showing no fibrosis, so no treatment. Second, you start the patient on treatment because now the viral load is high and you want her that she should be treated. C, the treatment should be started 4 weeks before the delivery or after the delivery, or you start the patient on prophylaxis against vertical transmission. What's your option? Please write down. Let's see what's the correct answer here. This is the start the patient on prophylaxis against vertical transmission. We shall discuss the concepts of prevention of vertical transmission and treatment of the mother. Which drug will you prescribe for the vertical transmission prevention? TAFE, TDF, entecavir, TDF plus peg interferon, entecavir plus peg interferon. Please write down your option. Whether you will use TAFE, you will use TDF for vertical transmission, entecavir, TDF plus peg interferon, or entecavir plus peg interferon. Let's see what is the correct answer. This is TDF. Let's see how the guidelines they recommend treatment in such cases. Pegylated interferon alpha is contraindicated in pregnancy. So those options are out. Tenofovir is category B drug. TDF. No enough data regarding TAFE being safe in pregnancy. Entecavir is a category C drug. So in this case, the TDF is the category B drug and should be given. The case history: patient was started on TDF 300 milligram per day. She wanted to know the duration for this medicine. So for how long will you give the drug? You started the treatment as indicated for prevention of the vertical transmission. Lifelong, because once treatment, lifelong treatment. Option B, till 2 years after PCR is negative. Option C, till PCR becomes negative. It may become negative 2 months after the delivery, or 1 year after the delivery, or 3 years after the delivery, you will continue the drug. Option D, 12 weeks after delivering the baby. And option E, 24 weeks after delivering the baby. So please write down your option, whether you would like to give this lady the TDF lifelong, or 2 years after PCR is negative, or till PCR becomes negative, or 12 weeks after delivering the baby, or 24 weeks after delivering the baby. Let's see what is the correct option. This is 12 weeks after delivering the baby. The EASL guidelines again, in pregnant women already on NA therapy, those ladies who are already using the drug for the indication being in themselves that the mother the lady was qualifying for the treatment and someone had started the treatment on treatment and she was not pregnant at that time. So one is that group that the lady become pregnant being on NA therapy. If she is on TDF, the same should be continued. If a lady who was on TDF before becoming pregnant, then after pregnancy, the same drug should be continued. If she is on entecavir or other NA, it should be switched to TDF. But if she was on entecavir or other drug like TAF, then that should be converted to TDF during pregnancy. If she is not on AVT, she should be started on TDF if she qualifies for antiviral treatment. So one scenario, a lady who was already on antiviral treatment and this was TDF, then this lady should continue the TDF during pregnancy as well. And the stopping rule will be as any other hepatitis B patient. But if the patient was on entecavir or TAF or other drug, then during pregnancy, this should be changed to TDF. Initially, we used to give them the lamivudine, but now the lamivudine is out. So if it is entecavir or TAF, then it should be converted to TDF during the whole pregnancy. But if she was not on antiviral treatment and on antenatal screening, she is found to be hepatitis B patient, and for herself, there's indication to start her on treatment, then she should be started on TDF. Another option is if she doesn't qualify for antiviral treatment, like this patient, she should be started on TDF as prophylaxis against vertical transmission if her viral load is more 200,000. Our HbS antigen level is more than 4 lakh per 10 international units per ml. So then if the patient is chronic hepatitis B patient, she has become pregnant, but for herself, she does not need treatment, she doesn't qualify for the treatment, then of course the vertical transmission prophylaxis should be considered in such patient, and the vertical transmission is started in the after 26 weeks, and it is the TDF, and the indication is the viral load or the HbS antigen levels. For prophylaxis, TDF should be started at week 24 to 28 of gestation, and continued for up to 12 weeks after delivery. Some people giving it to 24 weeks, but 12 weeks is enough. But if you consider, it may be extended to 24 weeks, but this is the that you start that patient and the 24 to 48 weeks of gestation with TTF, and you continue it throughout the pregnancy, and then 12 to 24 weeks. And of course, you give the vaccination to the HBV to the child as well. Her gynecologist asked you if whether she should do standard vaginal delivery or C-section in this patient. What would you advise for her? Number A, option A, standard vaginal delivery. Option B, standard vaginal delivery provided her HBV PCR has become negative. Option C, C-section if her PCR is still positive. Option D, C-section irrespective of PCR status, whether positive or negative. And option E, decision should be made according to her obstetric indication, not based on hepatitis B status. So what will be your suggestion or opinion or advice in such patient? Standard vaginal delivery, irrespective whether her PCR is positive or negative. Standard vaginal delivery provided her HBV PCR has become negative. C-section if her PCR is still positive. C-section irrespective of the PCR status, or this decision should be made according to her obstetric cause indication, not based on hepatitis B. I hope you selected your option. Let's see what is the correct option. Option is option E, that this decision whether she should have the standard vaginal delivery or C-section, it should be made according to her obstetric indications. So the case history continues. She delivered a healthy baby, a boy, at 40 weeks of gestation. It was a standard vaginal delivery with no immediate postpartum complications. What about the newborn? Mother has been given prophylaxis. Therefore, nothing is required for the newborn. One is this option. Option B is if mother's PCR has become negative, then nothing is required for the newborn. C, HBV should be given to the newborn within 12 weeks of delivery. Number D, vaccinate the newborn against HBV within 12 weeks of delivery. And number E, both HBV and HBV vaccination to the newborn within 12 weeks of delivery. So, one option is that as her mother has been given prophylaxis, therefore, nothing need to be done to the newborn. Second is, if her mother's PCR has become negative, then nothing is required, otherwise you do something. Option C, as the mother has been given antiviral drugs, just give HBV or vaccinate, or give HBV and vaccination both. What will be your option? Let's see what's the correct option. This is both HBV and HBV vaccination to the newborn within 12 hours of delivery. Question comes, can she breastfeed her baby? One option, no, due to risk of vertical transmission. Option B, no, but only after 12 weeks postpartum. Option C, yes, immediately after birth. Option D, yes, only if she is off treatment. Option E, only if her PCR is negative or when it becomes negative. So please note down your option. Whether she can breastfeed her baby, yes, immediately after birth. Only if her PCR, she's become off of the treatment. Only if her PCR is negative or she becomes negative, or whenever it becomes negative, or no, because of risk of vertical transmission, or no, but only after 12 weeks of postpartum. What is your option? What is your answer here? Let's see what's the correct option. Yes, her mother has been given vertical transmission prophylaxis. Baby has been given HBV and first dose of vaccine. So yes, immediately after birth, she can breastfeed her baby. What are these guidelines? Breastfeeding is not contraindicated in HbS antigen positive untreated women on TTF-based treatment or on prophylaxis against vertical transmission. So in neither category, it's contraindicated. So it is not contraindicated. The HbS antigen positive untreated women can breastfeed their babies. Those who are on TTF and those who have been given prophylaxis against vertical transmission. This is the safety and efficacy of tenofovir alafenamide fumarate in early middle pregnancy for mothers with chronic hepatitis B. This is the emerging data, and I would like to share with you that in this study, what they say that initiating tenofovir alafenamide fumarate in early and middle pregnancy appears safe for both mothers and infants, and it is effective for controlling maternal disease as well as interrupting mother to child transmission. So the data is coming, and probably in the future guidelines or the fresh guidelines, this may be an option. Second study is that the tenofovir alafenamide to prevent perinatal hepatitis B transmission. It was a multi-center prospective observational study, and what the authors conclude that antiviral prophylaxis with TAFE was determined to be generally safe for both mothers and infants and reduce the mother to child transmission rate to 0%. So data is there, and we hope that in the coming guidelines, probably this will be also an option. But till now, this is the TDF which has been a standardized practice to be considered in such patients. So, dear colleagues and PGs, the take-home message from this study is, this case study is that early recognition and screening of hepatitis B virus infection is required. The antiviral prophylaxis and neonatal immunization, that is active and passive, is efficacious and cost-effective strategy for prevention of vertical, that is the perinatal transmission of hepatitis B virus. Breastfeeding is not contraindicated in HBV infected mothers. And with this, I pay thanks to you to be with me in this series of case-based discussions. In the next episode, inshallah, we shall discuss the hepatitis B and hepatitis D co-infection, that how to treat these patients, what are the guidelines, when the treatment is required and when we should stop the treatment. It's again in another interesting everyday clinical practice scenario. Please be with me and we will see that how the guidelines help us in management of these patients. Till then, take care. Khuda Hafiz.